Everybody, my name is Ali Shamsi. Thank you very much for giving me the opportunity to make this presentation. It's an honor to be invited and a greater honor to have an audience with you my talk. A little bit about myself. I'm currently on the teaching faculty at Yale as assistant clinical professor of psychiatry. I also work for as a consultant psychiatrist for a company that does provide services to nursing homes in the U.S. I trained in geriatric psychiatry at Yale, and after that started practicing mostly nursing homes and geriatrics at this point. So, as you can see, is mood disorders in the elderly. It's important to be able to discuss. The elderly are the fastest growing population worldwide, in the developed countries, but also in developing countries, primarily because of advances in the last 100 years in public and in sanitation. It is possible now for individuals to live longer because of availability of antibiotics that are actually pretty cheap now. So we're seeing a larger and larger elderly population, and along with that comes a difference in presentation, where illnesses and psychiatric disorders are no different. Depression is around 8 to 16% in the general community population. So individuals who are 60 and older will have anywhere between 8% to double of that prevalent depression. Depression doesn't sometimes present on its own, but it's part of anxiety, and the prevalence of that is 1.8%. However, if you go into a population that is residential or in long-term care, in the different countries, it's population, basically, or in assisted living facilities. In developed countries, there's not so much of a demarcation between long-term care and community dwellers, but nevertheless, as individuals grow older, which is what the demographic population is for long-term care placement, the correlation between long-term care placement and dementia or disruptive family environment rises in prevalence remarkably to approximately 50% of depression, i.e., having some symptoms of depression, and 8% in primary care settings. So there's a huge jump in the prevalence of depression with advancing age. Why depression is important, as in any age group, depression tends to complicate medical illnesses and their management, also increases healthcare use, disability, and mortality. So from the perspective of primary care, depression presents as a major complicator of things. Compliance, hospital follow-ups, so forth, tend to be disruptive and in individuals who have depression. Who are depressed from the perspective of psychiatric services, depression adds to the discomfort, in that the elderly are miserably depressed, so to say. It adds to their own disability and the risk of morbidity rises significantly. When they get depressed, become miserably depressed, and the primary care services or other medical services that are trying to treat the elderly for other issues, illnesses, to have it difficult when they present with depression. Suicide in the Western Hemisphere is a growing problem, and at times surprisingly, but at times not surprisingly, the elderly population seems to be one of the fastest growing demographics that is actually completing suicide. So an early divorced or a widowed male is at very risk of actually completing suicide. Also, a proportion increase in completed suicide seen in females. So it's a bit of a complicating picture. On one hand, you see an increase in suicide in young adults, and the peak that happens in line prevalence of suicide happens in the elderly. Elderly are as much likely, perhaps even more likely, to actually complete a suicide attempt as a young adult in their teens or in their 20s. But what is to recognize what external authorities tend to call a subsyndromal depressive spectrum disorder. One fancy term for describing was a depressive-like presentation that elderly who may meet all the criteria for a major depressive disorder, but they tend to be very miserable, they tend to be despondent, and not to be very functional. So the experts try to this has two or more concurrent symptoms of depression, most or all of the time for at least 2 weeks. So overlaps with the symptoms of major depression, the parameters of major depression, but there are other criteria that are not as stringent. So there should be evidence of social dysfunction in patients who do not meet criteria for diagnosis of minor depression, major depression, or dystonic disorder. So there is a concession in the stringent on the bipolar disorder to begin with. So some permanent damage in the brain. There is this talk of always been there for many, many years now that perhaps late life depression is a precursor to dementia. And there is data to show that individuals with acute Alzheimer's dementia and they tended to have episodes of depression, at least one major depression, in 7 years preceding the onset of dementia. This is what we talked about. So those for depression are the same there for most diseases, as genetic and environmental factors, aging, having another neurodegenerative disease to begin with, having cerebrovascular disease processes, medical comorbidity, and what is becoming a catchword here in the United States is that what is good for the heart is good for the brain. So people ask, the baby boomers and others were nervous about getting demented old age. What can we do? And so this is what they're being told now. What is good for the heart is good for the brain. If hypertension, if you have high cholesterol, diabetes, so on and so forth, chances of you getting all the psychological and cognitive symptoms increases in late life. There are genetic markers and clues that suggest that perhaps having these genetic carriers and markers would predispose an individual to depressed life. These studies are small studies. They have good evidence, but they necessarily tend to get replicated. So these are genetic markers. The VAL on this gene substitution of VAL from MET, and so if you have MET6 allele, you have a chance of depression. If you have ApoE4 allele, is also associated with the chance of getting depression disease with anatomically correlate. And the same for the serotonin transporter LL gene genotype. Studies that show that there are certain genetic risk factors. These are puzzle. Genetic, as I said, tend to be small. They tend not to get replicated, and there are convincing evidence. So there are the usual anatomical correlates that we see with depression. There's reduction in gray matter in the areas of the brain that are associated with mood, functioning, and executive function, i.e., the orbital frontal cortex. There is reduction in molecular volume and deep white matter, deep inside the brain, is associated with what we were earlier talking about as vascular depression, and as an apathy, anergia, and anhedonia. Fungal imaging also points towards rates of certain risk factors showing up in the brain in imaging, and further adding to the fact that perhaps these risk factors are real risk factors and not just weak hypotheses. And so there is a trend to correlate findings with neuroimaging findings. So, and we're seeing that H2A receptor, this is one of the serotonin polymorphism receptor, is associated with depression. So treatment of depression. Let's come over to the treatment. We realize that treating elderly is tough. It is difficult because of various issues, because of certain comorbidity, as we talked about with medical conditions, hypertension, diabetes, sensitivity to medications, in renal function, and perhaps organ damage in other systems. Half of all adults with depression improve with initial antidepressant monotherapy. Anxiety tends to be a very complicating factor in depression in the elderly. The elderly tend to be very anxious, and comorbid anxiety, the outcome is poor. Low self-esteem, insomnia, issues with the elderly that only elderly will be able to tell you. There's disruption of the sleep-wake cycle, there's disruption of sleep stages in the elderly, and insomnia complicates treatment of depression. Reasonable expectations with that. Known in developing countries as well as developed countries is that disorders in the elderly is best treated in a multidisciplinary team, which is not surprising. Most mental illnesses are best treated in a multidisciplinary team with social workers, community workers, family, friends, nurses getting together, therapists, and provide to the elderly. And there were two studies, large studies that were done in the United States. The Prevent Suicide in Primary Care Elderly Collaborative Trial Prospect, which was a heavily funded study, and then the one by the acronym of IMPACT. And they pretty much show the same thing, that if you provide a multidisciplinary approach to treatment, the outcome of depression is better. What we need to know is that there is change in pharmacokinetics and pharmacodynamics of the drug in the elderly. The structure of the brain and other organs makes the elderly much more susceptible to toxic side effects of medication. And the rule of the thumb is when the elderly start low, go slow. So those are the same as in the general adult population, the same SSRI antidepressant, the same mood stabilizers, the same antipsychotics, and perhaps the effective dose might even be the same. But the way to reach that dose is the elderly. So you should start at 1/3 to half of the dose and go slowly. Start slow, go slow. You need to keep in mind that they have multiple medical problems. They might have cognitive impairment, dementia, and then just have neurological disorders like Parkinsonism, for example, or Parkinson's disease, for example, have a stroke. What's also important to keep in mind is to use augmentation strategies. This is uniquely different in the elder population. That you use full doses sometimes of medication because they are sensitive to side effects, and then you need to start using augmenting strategies. So you might need to use 2 different antidepressants, or you might use a benzo with antidepressant, or you need to use cognitive enhancers or cholinesterase inhibitors like Aricept, rivastigmine, perhaps Namenda, to work them up a little bit. This is a large, huge bipolar study that is being funded by the NIMH in the United States. A huge multi-center study, and results are sort of coming up. So what they've done is that they had a huge pool of patients, geriatric patients with bipolar disorder, and they them with DEOT or valproic acid and lithium, and they found that they were both as effective. And if you add on risperidone for treatment symptoms, you have good results. It is something that is being expected, that we all know, and this was just an attempt to get evidence for it. On top of this is that in the nursing homes of the United States, antipsychotics have been used abundantly, and so there is the need to cut down on these. Thank you very much for your attention. I'm open to questions, if you have any.
If you have questions in chat, and I'll unmute you.
हेलो
जी
जी हमारे से एक क्वेश्चन करेंगे अभी डॉक्टर साहब
जी
आई एम डॉक्टर तहसील मिर्जा फ्रॉम डिपार्टमेंट ऑफ साइकेट्री न्यू हॉस्पिटल and thank you very much for your informative talk on this important topic, and we have learned a lot of things out of that. The issue that is sometimes very tricky in elderly people is they are on polypharmacy most of the time. So if a person is on polypharmacy, can we attribute the depressive symptoms to some of the drugs he is taking, or when we start an antidepressant or lithium or valproic acid, should we take into consideration all the interactions it will have?
That's a very good question. It's a very good question. It's a very relevant question, and I'm glad you asked that. Yes, so polypharmacy is a very confusing and a very tricky issue in the geriatric population, which is why it tends to actually separate geriatric psychiatry from rest from an adult psychiatry because of the problem of polypharmacy. And you are right that there are medications that actually manage symptoms that we are going to treat. So for example, treatment for Parkinson's disease, Sinemet, for example, can make patients psychotic, and on one hand you have to be on these medications because they are stiff and cannot move around from Parkinson's disease. On the other hand, the very same treatment is giving them psychosis. We see this with beta blockers. We see this with a whole bunch of cardiac medications. So yes, and that is where the expertise of somebody with geriatric psychiatry comes in. Hence the need to have a multidisciplinary treatment approach. One needs to work very closely with the primary care physician. And your question on lithium and Depakote is absolutely on. Lithium is a very good mood stabilizer, but it is also very harmful, especially in the elderly when functions fall, renal clearance goes down, and God forbid that there is a patient on a diuretic or some other form of diuretic, and they are on lithium or they're on non-steroidal anti-inflammatory medication, NSAIDs, and they're on lithium, and if we are not monitoring them carefully for lithium levels, for creatinine levels, we are setting up for disaster.
I have a question regarding the slide which you mentioned, the 20% of the elder population having depression and bipolar disorder. So among those elder depressed patients, if you treat them with antidepressants and they are they just getting these antidepressants, they go to mania, how to tackle that? Like 10 and 20% of your geriatric patients with mood disorder have bipolar disorder. If you treat them with antidepressants, is it going to worsen their symptoms?
Especially high dose antidepressants. So the trick is to use just the right amount of antidepressant. You need to find out what exact symptoms of depression they have. If they have insomnia, for example, you need a different antidepressant. If they have hypersomnia, or if they're sleeping too much, you need a different antidepressant. But yes, this is extremely tricky. When somebody is depressed, and you do have to start them an antidepressant. If you are certain that they have bipolar disorder and they have had episodes of mania or hypomania, then you have to cover the antidepressant with a mood stabilizer. So Depakote, lithium, depending on what the physical condition is. But you cannot go very high on the dose of antidepressant. But you have to start them on a low dose of antidepressant till you get over this episode of depression, and then you can then successfully take them off the antidepressant, leave them with a mood stabilizer. It is very difficult, and it doesn't happen very often that you can resolve an episode of depression completely without the use of an antidepressant. So generally, you can use antidepressant, but low dose of antidepressant in the presence of a mood stabilizer.
Dr. Shamsi, one quick question. What would be your one favorite antidepressant for the elderly, if you were to name just one good antidepressant?
Well, there's several ones. There's some that are more commonly used, and there's some that are not that commonly used. So the commonly used ones in the elderly is mirtazapine. It's very commonly used in the elderly population, and then also citalopram and sertraline tend to be the more commonly used ones. Mirtazapine is used because it is an appetite stimulant, and it's also active antidepressants. Symptoms that are very commonly seen in geriatric depression: insomnia and loss of appetite, apathy, and failure to thrive. And these conditions, mirtazapine tends to have favorable side effects that you can use in your favor. Citalopram and sertraline tend to be sort of first-line SSRI antidepressants that are very good for anxiety. Some of the more heavy-duty antidepressants like Effexor, paroxetine, or venlafaxine, they tend not to be used so often in the geriatric population because they are sort of messy, they have a lot of interaction, they cause disruption in the metabolism of other medications, and they have serious side effects. So paroxetine can have a lot of anticholinergic side effects. Venlafaxine on high doses can also cause trouble hypertension, and they tend to have strong withdrawal symptoms. So the commonly used SSRI first-line antidepressants in the general adult population tend to be the same ones, with a few antidepressants that tend to be more favorable in their side effect profile to be used in the geriatric population.
Thank you very much.
DMC, I think the mic has some problem. If you have any question, you can ask in chat box, please. Dr. Saab, no more questions. Thank you very much, Dr. Saab, and thank you very much, everyone.
For inviting me. Thank you for listening to my talk. Thank you very much.
Thank you very much. Goodbye.